Associate Professor of Pediatrics, as well as a member of the Pediatric Advanced Cardiac Therapies program. Dr. Kaufman is the Director of Pediatric Cardiomyopathy, provides leadership for all outpatient programs in cardiomyopathy, which includes the Neuromuscular program at Stanford. And I'm going to let you go ahead and get started.
Great.
Fill
Thank
in the
you.
links for me.
Great. Thank you so much. Can everybody hear me okay? Did I put the mics on right? Great. Well, first I want to say this is my favorite thing that I do during the year in my role working with kids and families who have cardiac abnormalities from all different causes. And the neuromuscular population is a large part of my practice, but it's really one that honestly I am most excited about. You know, the short form name of our program is the heart failure team. And that's like really pessimistic. But really what we're about is really prevention of heart failure. And there is a huge spectrum. And what I'm most excited about with the neuromuscular population, specifically in boys with Duchenne Muscular Dystrophy, is that we can identify a population who is at risk of developing heart problems many, many years before that actually occurs. So it is a huge window and opportunity for prevention. While we're waiting for the cures to come up, there is really so many things that we can do to really modify the cardiac impact of having a dystrophin mutation and to really improve cardiac outcomes. So that's really what I will start to focus my talk on, is really to understand how does having a dystrophin abnormality affect the heart, and what does that look like through different stages of the life cycle, and what kind of interventions we can perform at all different stages of cardiac involvement. Okay. So how does DMD affect the heart? Well, as we know, we've heard there's 3 different types of muscle in the body: skeletal, cardiac, and smooth muscle. And the different types of muscle are not affected in the same way by having absence of dystrophin. If we zoom in on the heart muscle and the heart muscle cells, we see here that dystrophin is an important component of, let's say, the heart muscle contractile apparatus, is probably the most general way to say it. And so, yes, when you are missing dystrophin, it will affect, over time, the function of the heart and the efficiency of the contraction of the heart from a cellular basis, and then as it builds out, if you put all of those affected cells together. And that effect of, over time, how does the heart change by having one of the proteins in each functional unit of the heart, that process is called cardiac remodeling. And it's a spectrum. And early on, if you look towards the left, you may just see some EKG abnormalities, which actually can have several different causes of that. We see something called perhaps diastolic dysfunction, which is sort of a stiffness of the heart muscle. Kind of, if you think about filling a balloon, of trying to fill the heart chamber, if it's a thick walled, if it's stiff, it's a little bit harder to fill. And that's what diastolic dysfunction refers to. Different studies, such as cardiac MRI, we could see findings such as actual scar tissue, fibrosis. Over time, we can see the ventricles start to dilate. And then it's typically at those stages where we see systolic dysfunction, where the squeeze of the heart starts to get affected. And that can progress to what's called end-stage heart failure. So it's a progression over time. But important to realize is that by having a genetic abnormality, which we call genotype, having cardiomyopathy, which is an abnormality of the heart muscle and/or function, and having actual heart failure, which is a syndrome of the inability of the heart to keep up with the body's metabolic demands. Those are not synonymous, and I think that's important to hold on to. We do think of these stages, though, as different targets of intervention, because of course our goal is to totally prevent. We don't want heart failure to happen. Many, many people live very well, healthy, feeling good, even though they have cardiomyopathy. And so you can see this is in your eyes. This arrow here is a bit blurry because, of course, our goal is to interfere here, is to prevent the onset of cardiomyopathy from having abnormal dystrophin. But while we're working on this, This is our target as cardiologists in the field of preventing the transition from cardiomyopathy to heart failure. And there's very well-established therapies for this. Because while in DMD, the abnormality is an alteration in the dystrophin gene, there are many other forms of cardiomyopathies that are also affected by a genetic change in one of the heart muscle components. And so really the models we use for dilated cardiomyopathies of many different etiologies is all very relative to Duchenne muscular dystrophy as well. And this is a field that's getting more and more established and effective, particularly in pediatric cardiomyopathy and heart failure. So cardiomyopathy, what are the signs and symptoms, right? Well, kind of sometimes, the reassuring part, sometimes the scary part is that there's typically none. That you actively need to look for to see, is there some abnormality in the heart muscle? There is sometimes we can see the heart rate start to rise. If there's problems, typically at more further progressed stage, you can have palpitations, abnormal electrical activity of the heart, and you could have some increased work of breathing with exertion. And of course, exertion is all relative to your child. What is exertional for your child? And there are many different regimens on how to screen to detect these. Most common is echocardiogram, with a standard regimen being screening every 2 to 3 years until age 9 and then annually. There's lots of utility for cardiac MRI, and some programs use nuclear imaging studies, and as well as monitoring for rhythm abnormalities of electrocardiograms and Holter monitors. And again, our goal is really to prevent and delay the progression of cardiomyopathy. And how do we do that? Well, we have several medications that can actually decrease that cardiac remodeling process that I outlined. Many of these medications, many you've heard of. I don't know if any of your children are on any of these medications. The categories are called ACE inhibitors, which are angiotensin converting enzyme 2 inhibitors, such as enalapril, lisinopril, benzapril. Aldosterone blockers, called spironolactone, and there's a newer one called eplerenone. And then beta-adrenergic receptor blockers called carvedilol. And these are standard of care in both adults and children with cardiomyopathy from any etiology. Most important though, and I think a huge opportunity with preventing heart failure in Duchenne muscular dystrophy, is treating the modifiers of disease. And as we've been hearing from Dr. Bachrach and from our neurology team and everything, that there are the systemic impacts of Duchenne muscular dystrophy, many of them can have cardiac effects irregardless of the actual cardiac function. And that I'm really referring to respiratory status, really avoiding obstructive sleep apnea, supporting respirations efficiently, preventing hypertension, which in some can be problems if you're on chronic steroid therapy, and weight management, where we've spoken about the effects of weight gain when you're on chronic steroids, but there are also many children who struggle with maintaining their state of nutrition, and malnutrition can have as many as adverse effects on cardiac function. And then, of course, being aware of high-risk situations. So, for instance, scoliosis surgery is a pretty common surgery in people with muscular dystrophy. Now, it's very important to have a strategy with the anesthesia team, with postoperative management, that just to at least realize, well, this child might not have normal cardiac reserve, and to sort of think proactively about what can we do to minimize any stress on the heart during these procedures. Particularly even easy things. Make sure you have a recent cardiac evaluation as part of your pre-op planning. If it's been several years, that's a good time to get a cardiac evaluation as part of your pre-op checklist. So let me just talk a little bit about heart failure. But actually, even before I go into heart failure, I think one thing to why I think prevention and screening is so important, and sort of one of the changes in our modern day management and our changing outcomes in the new prognosis, is that there used to just be, well, heart failure will happen and there's nothing that we can do about it. And that is dramatically changed. And that it's really about knowing that, hey, you can have significant heart muscle weakness without having any symptoms at all. And just by incorporating that knowledge into your annual maintenance visit, that in and of itself, just to suspect it, to search for it, to know it's there so then we can manage it, that is the key to preventing symptomatic heart failure. And that's like my whole take-home point. We could have coffee now, but that is what it's all about. But I do think it's also important to talk about heart failure, because it does still happen. And we're actually getting better and better at treating that and managing that, and there's many more options available for children with all kinds of heart failure. So I am going to go in and talk a bit about that. So what is heart failure? It's really just imbalance of supply and demand, inadequate blood flow to meet the organ's needs. And the body compensates by this fight or flight system, right? Your kidneys, your brain is saying, hey, I'm not getting enough blood flow, so I'm going to, surge a bunch of adrenaline into my system. And that adrenaline surge makes you tachycardic, makes your heart rate high, constricts your blood vessels, and actually makes your body hold on to salt and water. And that salt and water can accumulate in the lungs, in the liver, in the tissues, actually in your gut as well. So maybe not feeling so hungry or having some feeding and feeds intolerance could be a sign of congestion, which is our word for water retention. There's actually cellular changes in the heart, and that's part of that cardiac remodeling that we were talking about, where actually some of the heart muscle cells are damaged, and then the cells that then right next to them have to work harder, so they get enlarged. Scar tissue forms in between the cells, and that all leads to the heart chamber becoming stiff and weakening. So early manifestations of heart failure often go unrecognized in kids with muscular dystrophy because most of the symptoms are associated with exercise and exertion. And at the time that cardiomyopathy starts, in typical boys with Duchenne, they are almost uniformly non-ambulatory. This is really something that first starts, in certainly the earliest cases have been reported at age 9, but much, much more common in the teenage years as we move to the late teenage years. So again, unless you're searching for it, there could be significant heart weakness, but if you're non-ambulatory, you're not getting tired with running or with different types of exertion. That being said, and as you all know, there is a lot of exercise and physical activity in relative exertion. Goodness, I remember last time I saw the wheelchair games. I don't know if anyone is involved in this with soccer, but really paying attention to physical therapy, to transfers, to anything that is exertional, depending on what stage that your son is in, that these are the symptoms to look for. The other thing you may notice as you look at, symptoms on the left side, they're all really nonspecific, kind of fatigue and cough and loss of appetite and abdominal pain. 99% of the time, those symptoms really will just be the flu. It will be a cold, it will be food poisoning. It will all be all of the standard things that all normal kids get. But the point is, if things aren't going right, if it's like, wow, it's like 2 weeks now and everyone else got better from the illness, why is that flu still hanging around? How come that cough never goes away? How come, you used to have a great appetite and now just something has changed? That nuance which you all will know, that something is not right. And just to think of the heart, and that in and of itself, just thinking of the heart, will lead you to getting screened and early detection. Right? So I don't want everyone to leave here and if someone has a cough or cold that you're going to get nervous about it. Okay? Promise me that. You need to be empowered, just like trusting yourself that you will know that if something is not right or not making sense, just to think about the heart. Right? And there are different signs that we can look for on physical exam. So again, I spoke about balancing cardiac supply and metabolic demands. And if we think about energy is required not only for breathing and movement, but eating and fighting infections, surgical healing. And what we try to do to balance it is really to optimize blood flow to the organs and tissues. And yes, that is with medications, but it's also with fluid management, really important in post-op situations, good nutrition. And if there are stages of severe heart failure, we actually have mechanical support options now. So I sort of break heart failure therapies into 3 boxes. Treatment of disease modifiers, which I cannot overemphasize, different medications, both oral and IV, and ventilatory support, again, balancing out that supply and demand. Now, when we think of advanced heart failure therapies, again, this is the field in my world which is expanding at the greatest pace and is really benefiting the children that need it. Again, I'll say 10 times, my goal with all of yours is to prevent this stage. But if this happens, we really have, a more full toolbox is the best way to say, of what we can use to effectively treat advanced heart failure in children. So if you're having rhythm abnormalities, we have arrhythmia therapies and something called cardiac resynchronization therapy. The downside is, of course, getting inappropriate shocks and complications of pacemaker devices. We have these mechanical circulatory support options, which are basically mechanical heart pumps. Similar, if you think about our high-tech power wheelchair now, think of that as a high-tech power support for the heart. But of course, it's placed with an operation, and it's internal. There are different risks and benefits to that. The main thing is you need to remain on anticoagulation, and it's the balancing act between keeping the blood thin enough so the device works, but not at risk of bleeding or clots, and I'll talk a little bit more about that. And then, in some cases, we have advanced heart failure therapies that involve heart transplant. And again, everything is a risk-benefit assessment. The heart transplant comes with lifelong immunosuppression. And it's really those adverse effects of medications, of immunosuppression, that leads to the risk associated with heart transplant. The other important thing is that there is no pulmonary support, either with mechanical circulatory support devices or heart transplants. So we're still in that challenge of if we really are at these advanced stages, which is I'm happy to say, is becoming rare. But when it does occur, these are the challenges of our advanced heart therapies specific to muscular dystrophy. So again, I'm going to take one moment to talk about these ventricular assist devices, because this is pioneering therapy in our field. And these are all mechanical devices. They used to be these big things, but now really the size of a quarter. And they're devices that are implanted into the heart and kind of bypass the heart pump, so it's able to deliver the circulation. And they're now in this ambulatory state where all you see is a drive line, literally like a little power cord for a phone, that comes out and connects to a controller and is run by batteries that can be worn as a vest or hung over a shoulder. This is Edgar. I have his permission to show this here. Now, Edgar is one example of our expanding use of ventricular assist devices in boys with muscular dystrophy. He does have a Becker's form of muscular dystrophy, though somewhat of a mixed phenotype. And when he had his device implanted, he was still, I would say, at least partially ambulatory. He currently is, we just celebrated his 5-year anniversary on device. He is wheelchair bound at this point, but this device has been functioning very well for him. So much that we actually offered him heart transplant, and he decided he wanted to stay on the device, right? But again, the downsides is that you do have to have lung support. You do need to remain anticoagulated. Same way as with any machine, there are complications, and it's always balancing the risk of stroke and infection. But sort of in the field of advanced heart therapy care, this is our future of really having, the industry is really working on developing smaller and smaller mechanical devices with longer lasting batteries and mastering the anticoagulation, really to really further the care of heart support in any different disease. So in summary, I would say our goal is to cure the disease. If we can't cure it, our goal is to stay here. Asymptomatic cardiomyopathy, where we use oral medications to delay the progression of the disease. We treat disease modifiers, pulmonary support, healthy weight maintenance. We monitor to detect cardiomyopathy changes, and really key thing is early detection of any symptoms. If we do get into a stage of heart failure symptoms, our goal is to remain compensated from that, in balance, right? And we do those different things by managing fluid and salt intake and doing whatever we can to decrease the work of the heart that the heart needs to do. And then in stages, if there are cases of decompensated heart failure, of instability, we do everything we can, of course, to reduce morbidity and mortality, to restore circulation, and really to maximize quality of life and functional capacity. There's also now, as I mentioned with VAD and transplant, there are options for longer-term advanced heart failure therapies in this stage. But really our goal, and what I do believe we're getting more and more successful at, and let me just say I think we're very successful at, is maintaining in this state here. And that's all because of the multidisciplinary efforts of involving cardiac right from the beginning of education so that we can be proactive about it. And so as I said here, it really is a multidisciplinary team, and everyone is involved in order to promote lifelong cardiac health. The heart failure community in pediatrics has absolutely 100% embraced the Duchenne Muscular Dystrophy and other patient populations with neuromuscular diseases, and is 100% committed to furthering research in those efforts and optimizing care guidelines. So now with every recent pediatric heart failure guidelines, there is a section included on neuromuscular diseases. And this is just one of the more recent in 2014 from the International Society of Heart and Lung Transplant. And one thing I would say that, that we have here, so as many of these guidelines go, they review all of the available literature, all of the case reports and the huge clinical trials, and based on analysis by a group of experts of all of the available clinical trials and scientific information, recommendations are made, saying based on our degree of knowledge and what that level of evidence is, this would be our recommendations. Absolutely likely to help, likely to help but not supported by multiple clinical trials, or likely to harm. Those are the categories, standard categories of recommendations here. And so 2A recommendations that the weight of evidence is in favor of usefulness is that basically screening should be involved, medical management, and basically everything I described to you today is standard of care of managing children with any form of cardiomyopathy or genetic risk for cardiomyopathy. We also support the use of steroids, as we just heard, likely to delay. But if you look here, the level of evidence is C, which is our lowest level of evidence. It's saying based on consensus opinion, but not based on good data, that those are our recommendations. And that's one of the biggest challenges in knowing for sure what can we do to better treat and prevent cardiomyopathy in DMD. The numbers are small. The best cardiac trials still have less patients in them than are physically sitting in this room. Okay? And with that, the changes that we see of cardiac function happen over years and are happening when the children are older. And we have not done those trials in that population over the period of at least 3 to 5 years that needs to be done, and hundreds of kids receiving a treatment and hundreds of not, and comparing them to really know for sure, does steroids make a difference? Does eplerenone make a difference? Does lisinopril make a difference? Does losartan make a difference? And I don't say that to be Debbie Downer. I just say that there's a lot that we don't know. And just wearing the hat of a cardiologist, we often think of medications like theoretically they should absolutely work. And then in the field of adult heart failure, where they actually trial these in that most rigid scientific manner, even the drugs that theoretically should help, they have found that sometimes they don't, sometimes they've been harm, or sometimes they've been unequivocal. So we struggle about that, in the pediatric heart failure world. Well, how do we know what's to work, what's harmful? And we've had some small trials that also can be the information translated to boys with DMD. One was most the Carvedilol trial, where again, the numbers are still, even with everyone coming together, are relatively small to try to find a dramatic effect. So what I would say with all of the trials and studies that are being done, and they are, is really to put pressure on, we need a larger effort. We need government funding for large research trials for cardiac outcomes. But they are incredibly expensive and long-term, so there are challenges to that. But that being said, this is something to discuss with your cardiologist. If you see a news article, if you find a publication, can this drug work? What do you think of this drug? What do you think of nutrition? Have the conversation, because it's that sort of putting things in perspective of the particular state of your child, the relative risk and benefits, where that conversation can help me make choices. Okay, is it reasonable to try this, even though we don't know 100% that it's going to work? Or, well, let's reconsider it because there are some unknown risks, and really we don't know the true benefits. So that's just kind of a little bit of putting our current state of research into context. But sort of managing the progression with ACE inhibitors, beta blockers, all of that really is something that, at very least experientially, as well as some data-driven trials as well, can really make a difference in really prolonging life, maintaining good cardiac health. And I'm happy to talk with anyone more specifically after our talk. And this, again, comes to what we were talking about with the use of mechanical circulatory support and transplant. The fact that this is now in our standard guidelines, saying, okay, well, it's unestablished, expert consensus opinion says it should be considered on a case-by-case basis. That is actually a huge advance. the fact that this is being considered instead of just saying, no, you have this diagnosis, no go, right? And that's the way it used to be. Insurance companies wouldn't even think of it to pay for it. And now it's really a case-by-case study of what are the relative risk and benefits for each individual. So again, that may not seem like an advance, but it really is. So I will leave it there, and again, just to really summarize with a high note that I really do think that it's about lifelong cardiac care, starting from the time of diagnosis, starting from coming to events like this, of education. It's a hard topic to think about and talk about, but it's really that dramatic differences in outcome can be made by thinking of it early, by managing and prevention and treating modifiers of disease. So I'll leave you with that. Thank you very much.